Well, I really appreciate the invitation from President Margulies to give this lecture, and in honor of Dr. Poth on the 55th anniversary of his presidency. Just a little background, since I had forgotten it since last year's lecture, just to review. Dr. Poth was a Texas native, did his undergraduate work at the University of Texas, obtained a PhD at Cal, moved back east to Johns Hopkins for his MD, then performed surgical residency at Stanford, and from there, after a brief stint on faculty, went to his career destination, which was the UT Medical Branch at Galveston. There, he directed the Surgical Research Laboratory for nearly 20 years. He took the Ashbel Smith Professorship of Surgery in 1964, served on the ACS Board of Governors for about 10 years. He authored some 160 papers in his career and is known for his writings on the management of bacterial growth associated with surgical diseases of the intestinal tract. I went back and looked at his presidential address, and it was interesting. I had chosen this topic before I learned about this, but I have taken a couple of excerpts from it. One thing that he wrote, and this is 55 years ago: the massive information on which medicine is based is so overwhelming that it's utterly impossible for a person to acquire a sufficient depth of knowledge to become truly proficient. Time runs out on all of us long before we can acquire and retain the factual mass. I wonder what he would say today with the explosion of medical information. He went on to say it's necessary to record these data in something other than the human mind. Not only must it be recorded accurately and kept current, it must also be immediately available. This machine must also be able to indicate what happens when a variable, such as disease with its physiologic abnormalities, is introduced. The answer must be available in seconds. These aren't daydreams. Computer systems can be programmed to do this. But one must remember, a computer can handle only factual data. It doesn't have the capacity to reason, and it doesn't possess judgment. Remember that information fed into such a system must be accurate. This statement means both the information stored in the system as well as the information supplied to it for analysis must be correct. The questions asked must be soluble, or the computer just stalls. It will not make a silk purse from a sow's ear. Now, I don't know what that last thing means, but I've heard it out of the mouths of Texans before. But I think the parallels between this and what I'm going to talk about were kind of interesting to me, because we do have a lot of literature to sift through, a lot of medical information, and in order to make good decisions, we need to use good information, we need to update it, we need to process it, asking the right questions, and that's hopefully what I'm going to convey today. Now, I don't have any financial disclosures, but I do have one, and I think this is crap, and I am going to use the term evidence-based in this talk. And I think we need to continue to use evidence-based medicine in the scientific community. Now, as I was thinking back, trying to figure out where I got this interest, well, I do know, but I was thinking back to my medical school, not to malign the training that I got, but during my third year of medical school, I couldn't think of a single instance where somebody started talking about current literature. When I asked a question on OB, the mean OB resident said, well, just read the book. You know, every rotation you have a book of basics for that rotation, tells you what magnesium does, and you know, you'd have your surgery books and your pediatric books, but nobody ever talked about current literature. And it wasn't until my fourth year, I remember a rotation on cardiology, and the cardiology fellow would stand there, and on rounds every day I heard about Timmy 2, Timmy 2, Timmy 2. I said, who's Timmy, and how many Timmys are there? He would talk about Timmy 2 every day, and this is what I remember from medical school about evidence. But I think where it really was instilled in me was residency. I was very fortunate to go to the University of Colorado, and these were my two primary mentors there. On the right is Alden Harkin, who was chair of surgery throughout my training. And on the left, Gene Moore, the vice chair and the chief of surgery at Denver General for many, many years. And I remember during the interview and continuing the interviews every year, Gene made it clear that if you come to this program, you will be expected to read not just textbooks, but current literature. And that was the practice there. That was the culture, that you would keep up And every time we had ICU rounds, which is 3 times a week early in the training, you would talk about the literature, and either you would be following that practice, or you would change your practice, or you'd decide to study it. And one journal club, my first rotation ever at Denver General, we had a journal club, and Gene Moore, as usually, pounded his fist. He said, I challenge anybody to look at the data on this and see if this is right. And I went up afterward, I said, Dr. Moore, I'd like to do that. He said, great. And that became the first paper I ever wrote, and I presented it at this meeting in 1994. And that was a very important thing for me. And the culture in the program, not just at Denver General, but throughout the program, is what are the data? You couldn't just give the right answer. It was like 3rd grade math. You say 9. Well, great, no credit, show your work. And in the residency program, it wasn't enough to say, I'd take out the gallbladder. Oh, you would? Why? When? What are the indications? And what if you don't do it? Are you going to do a cholangiogram? You had to know what you were going to do and have the basis for it. And that was the culture. Now, Dr. Harkin had a unique program of grand rounds every week where we did resident debates. And I think my colleagues underappreciated this. This was a phenomenal opportunity for us to learn how to do research, how to put a talk together, to practice public speaking, and to look at the literature critically. Because you could go into this with a bias and you could get the good side going in, but you had to read that literature and find the holes in the good side to defend your position. And if you got the bad side, you were finding the holes in the other side's literature. So you could learn to make an argument out of it, but you really learned how to read it and apply it. And that was very valuable for me, and I know it made me a better surgeon. Now, this was a recent piece in the New England Journal talking about medical education in the era of alternative facts, and when you talk about fabrications masquerading as reality. But the idea here is that there's an environment of mistrust in some areas, and it's important for us as educators to create a lifelong appreciation for the importance of hypothesis testing, peer review, and critical analysis of research. And I think anyone in a teaching environment, and we all should consider ourselves that because we're all teaching each other every day, should take note of this and encourage this behavior amongst all of our colleagues. So it's important for patient care, it's important for teaching, but it's also important when we talk to our patients. We aren't doing informed consent if we're not talking to our patients about all the alternatives and the expected outcomes. And to do that, you've got to know the data. It's not enough to send the intern in and tell them to get consent for the appendectomy. And I'll talk more about that later in this. But these days, it's not acceptable to just tell the patient what's going to happen to them, because they've got questions and we owe it to them. You wouldn't accept it yourself. Informed consent can take these two extremes. Well, on the one hand, you can just say, this is really going to suck, sign here. Or you could leave it to the patient. But informed consent is really somewhere in the middle, and you have to talk to them about all the expectations. All right, so I'm going to talk about evidence-based medicine. And when you read about the movement, as I'll call it, the people point to this paper as the first time that an organization really put evidence ratings on recommendations. The Canadian Task Force on the Periodic Health Examination had the objective to recommend a plan for a lifetime program of periodic health assessments. And they graded things. There was level 1 evidence, and that was what came from prospective randomized trials. Level 2 evidence from cohort or case control studies, and so on. The simplicity was apparent, both a blessing and a curse, but there was some judgment in there. For example, what is a poorly designed prospective study really level 1 evidence, or what happens when you have two that conflict? But nevertheless, this was certainly the first foray. Now, the formal evidence-based medicine movement goes back to this. These clinical epidemiologists at McMaster University published this in 1992. And I'll read this. They wrote, "A new paradigm for medical practice is emerging. Evidence-based medicine de-emphasizes intuition, unsystematic clinical experience, and pathophysiologic rationale as sufficient grounds for clinical decision-making. It stresses the examination of evidence from clinical research. Evidence-based medicine requires new skills of the physician, including efficient literature searching and the application of formal rules of evidence evaluating the clinical literature. So this blew away the concept of who the best physician is. And I know in my family, they're always looking for the gray-haired doctor. I'd talk to my family like, oh, my niece has appendicitis. Did she go to the children's hospital? No, we don't want her to see an intern. We went to the community hospital. It's 5 miles further away. The Marcus Welby, who understands disease and his experience, is less valued in this evidence-based medicine process, but rather you want the young person who's computer savvy, who can read and interpret the literature and apply it, and the experience is really thrown out the window. So a lot has been written about the process and how things get through the system from research to ultimate implementation and practice. But regarding evidence-based medicine, what they want people to understand is they want patients, practitioners, healthcare managers, and policymakers to pay attention to the best findings of healthcare research that is scientifically valid and ready for clinical application. The New York Times Magazine Year in Review included this as one of the most influential ideas of 2001. As I just mentioned, that it was introduced in 1992, so this is part of the issue. Things take years to get permeated into the public consciousness. But nevertheless, it was a big idea when it did come around. Now, there are many challenges of this. Now, first, there's incremental advance of knowledge. We all understand this. There are many missteps along the way. You see as you read the literature, there are positive trials, negative trials. There are some that you know about that never get published. Their breakthroughs, the real breakthroughs, are few and far between, the real game-changing findings. And so things don't change overnight. In addition, a minuscule fraction of the published literature is both adequately tested and sufficiently important to change our practice immediately. And another challenge is that the average practitioner has limited time and limited understanding of research methods. So you put a paper in front of somebody and they may just accept it without understanding the flaws in it. So the solution, as the evidence-based medicine advocates propose, is to eschew reading original medical literature, but rather find the right pre-assessed research evidence, determine whether it applies to the problem at hand, and then work it into decision-making. But beware the individual authority, the so-called expert, or worse yet, the collective medical authority, the panel of experts convened by a professional society to provide practice guidelines. The premise there is that these experts are more fallible in their recommendations compared with evidence derived from sound, systematic research. Now, the Cochrane collaboration was established in line with this movement. In 1993, the objective was to evaluate available evidence for randomized controlled trials, assuming that interventions are more effective if based on complete and up-to-date evidence rather than out-of-date research, anecdote, or conjecture. And the eventual goal was to have a register of all complete and continuing randomized trials, to combine the results of trials that meet set standards, produce regularly updated systematic reviews, and make these reviews widely available. I think in general it has achieved that. Some early criticisms were addressed, but initially non-randomized studies were excluded. And as we know, in areas such as surgery, randomized trials can be logistically difficult or impossible, in addition to being ethically challenging to perform in some cases. There was no external peer review of the Cochrane review in its early beginnings. And the third part of this, what do you do when the data are inconclusive? You're left not knowing whether to scratch your head or your nether regions. And I'm going to show you an example of why I decided I hated the Cochrane review a few years ago. The topic of appendectomy versus antibiotic treatment for acute appendicitis was reviewed in 2011. 5 randomized controlled trials. The primary outcome, cure within 2 weeks without major complications in a year. I think that's a pretty good outcome to assess. And here are the data. In the group treated with antibiotics, 5 trials, on average, 73% of patients achieved the primary outcome. and the various studies range from 60% to 85%. The appendectomy group, on the other hand, achieved the primary outcome in 97%, with a range from 92.5% to 98.9%. So to me, that's pretty clear. I know what I'm going to propose to the patient. But the Cochrane Review, of course, because this is evidence-based medicine, and they said, well, the quality of the studies was low to moderate, and for that reason, the results should be interpreted with caution, and definite conclusions cannot be made. This is a prime example of something where we have to make a decision, and so this I don't consider very helpful in clinical practice. And as this evidence-based medicine movement rolled out, you heard things like this. You'll hear people talk about this. If they don't reference this, they're just being copycats. But this tongue-in-cheek proposal that radical protagonists of evidence-based medicine should organize and participate in a double-blind, randomized, placebo-controlled crossover trial of the parachute, because there is no level 1 evidence that it works. So those people who are so adamant that we need to have evidence for everything we do can jump out of a plane. Now, recently, in order to standardize the grading of studies in guidelines, this grade methodology has been adopted. So I wanted to take a few minutes to review it. This is actually done about 10 years ago in a series of 5 papers published in the British Medical Journal. And they have, there were a number of advantages of grade over other systems, and they're listed here. A widely representative group of international guideline developers participated. There's a clear separation between the quality of evidence and strength of recommendations. I'll talk about that in a minute. There's explicit evaluation of the importance of outcomes of alternative management strategies, explicit comprehensive criteria for downgrading and upgrading quality of evidence ratings, a transparent process of moving from evidence to recommendations, explicit acknowledgement of values and preferences, clear and pragmatic interpretation of strong versus weak recommendations, and it's useful for systematic reviews and health technology assessments as well as guidelines. You see that the quality of evidence definitions listed here. So high quality evidence is that in which further research is very unlikely to change our confidence in the estimate of effect. Now, in contrast, low quality, further research is very likely to have an important impact on our confidence in the estimate of effect. So this is how you will find a lot of papers assessed currently. Now, we recognize that healthcare decision-making involves a risk-benefit of alternative strategies, but you have to factor in that the decision is influenced by the magnitude of risk and benefits, and as well as the confidence in the estimates. And here the weatherman is saying, I figure there's a 40% chance of showers and a 10% chance we know what we're talking about. So your confidence in the numbers has to factor into how strongly you will rely on the data. Now, what is quality of evidence? Why is it important to clinicians? The guidelines should address clear questions and address the importance of outcomes. And here is an example where, obviously mortality, myocardial infarction, fractures, these are potential side effects of a drug used for a medical condition. These would be outcomes of high importance. On the other hand, flatulence would be considered a side effect that's of less importance in deciding whether to prescribe that drug. And so these things should also factor in. We need to consider the context and the study design in judging the quality of evidence. And so factors that affect our assessment of the quality include limitations of the study, inconsistency of the results, imprecision, publication bias. On the other hand, large magnitude of effect or dose-response gradient, these would increase the quality of the evidence in the grading. And then going from evidence to recommendations, the strength of recommendations is based on the desirable versus undesirable side effects, the quality of the evidence, the values and preferences, and the cost or resource allocations. So in the grading, you'll have a quality of evidence score, and then a strength of recommendation, either strong or weak recommendation for using an intervention, or strong or weak recommendation against using the intervention. Then As far as getting ideas from research into implementation, there have been a number of studies referenced here that have all estimated a time lag of 17 years in this process to make it through from basic research, clinical research, guideline recommendation, and then implementation in practice. So it is a long process, and there are a lot of factors that will impact that. This group reviewed implementation strategies and found that there are a few things that that do influence it. One is whether you have multiple component strategies for conveying the guidelines versus single strategies. The guideline characteristics, if it's cheap and easy, that has the best chance of implementation. If the professionals who are involved in implementing it are aware and familiar, how many policies at your hospital have you never been made aware of? And the nurse will tell you, oh, that's a policy. I've never seen it. Okay. Patient characteristics. We can always find excuses not to apply guidelines to our patient because this one's got a comorbidity, that one's non-compliant, it's not going to work. And those will impact our implementation of things. And then finally, environmental characteristics. If we don't have support from our peers or superiors, if we have insufficient staff or time, things are less likely to be implemented. Other factors that impact translating guidelines into practice, one of them, this group suggests that there are too many clinical reports and best practice advices, policy statements, things without a strong evidence base, and so it clutters the literature with recommendations. So if we reduce the volume of it to high impact guidelines, it would make it easier to accept and implement. Improving integration of guidelines into electronic health records and HIT systems would help. Starting to introduce this during training would make a difference as well. Changing the curricula of health affairs schools to incorporate high quality improvement and change management skills. And then I think a good recommendation is to align these with maintenance of certification activities. Take those guidelines of high importance and make those part of the maintenance of certification in a specialty. All right, enough of the boring stuff. I'm going to talk about some examples of how I see us using the evidence that we have in practice, because the reality is that in trauma and all of acute care surgery, we do not have a lot of high evidence-based guidelines. So what do we do when we don't have guidelines? Well, here is a paper from 1990, a randomized controlled trial of methylprednisolone or naloxone in the treatment of acute spinal cord injury, also known as the NASCUS-2 study. How many people were named in a lawsuit over steroids after spinal cord injury? Am I the only one? It was really just a notice of claim. This went from publication to standard of care in a relatively short amount of time. The accompanying editorial when this was published said, "This is good news. After 20 years of research and studies in animals, we now have evidence that a medication can reduce some of the damage that results from acute spinal injury." And this was implemented almost immediately after publication in this journal. Well, for those of you who do trauma, you probably know that the pendulum has swung on this issue over the years. Now, this is a clinical practice guideline that was just published last year on this topic. And they talk about the extensive use over the past several decades, but that it is inconsistent. And what they point out is that 2 clinical practice guidelines were developed by these experts, the Congress of Neurological Surgeons and the American Association of Neurological Surgeons. Despite a similar evidence base, there were significant differences in the recommendations they proposed in 2002 versus 2013. In 2002, the expert panel recommended the administration of steroids for 24 or 48 hours in patients with spinal cord injury, with the caveat that this treatment should be undertaken knowing that the evidence suggested harmful side effects, and that evidence was more consistent than any suggestion of clinical benefit. In contrast, the 2013 guidelines proposed a level 1 recommendation against the use of steroids based on the following reasoning: that methylprednisolone is not approved by the FDA for this application, there's no class 1 or class 2 evidence supporting a clinical benefit, And there is class 1, 2, and 3 evidence indicated that high-dose steroids are associated with harmful side effects. Now keep in mind, there weren't any very big randomized studies performed during this time period. All of that data had come from previously, but people started reanalyzing it. Well, this group took these principles of guideline standardization and grade methodology and went back through the data, and now they put forth these recommendations. So they're suggesting a 24-hour infusion of high-dose methylprednisolone be offered to adult patients within 8 hours of acute spinal cord injury as an option. Moderate quality of evidence, weak recommendation. Now they suggest not offering it to patients more than 8 hours after injury and not offering a 48-hour infusion to anybody. Now it would be interesting to see how this rolls out, and I would show this to your spine surgeons to see what their take on it is, because I haven't seen anybody give methylprednisolone to a spinal cord injury patient in years. And what is pointed out is that the gain in the motor function is just a few points, and so it really should be focused on patients who have the chance of some functional recovery. For example, a mid to low cervical spine injury, because the difference between being on a ventilator or being able to push your wheelchair is huge, whereas if it's mid-thoracic in a little old lady, their chance of pneumonia is much more significant. So this is one of those interesting things that we've seen move, and again, based on low quality of evidence, a big swing in practice and a big swing in recommendations. Now, when I was putting this together, I was interested because I've always thought of the New England Journal as a very high-impact journal. I mean, not just because it is, but because the articles that are in there, like TIMI 2, like the NASCUS 2, these get attention and these change practice. So you can search on the website for all the prospective randomized trials, and you can sort them by the most cited. And it turns out that 3 of the top 5 most cited papers out of over 2,700 prospective randomized studies, 3 of the top 5 were in critical care and all published in 2001. So I'm going to talk about where these papers are now. There's the intensive insulin therapy in critically ill patients, Vandenberg study. This recommended a target glucose level of 80 to 110 milligrams per deciliter in our ICU patients who are on ventilators. The Rivers study, early goal-directed therapy in the treatment of severe sepsis and septic shock. This published in 2001, and this laid out a protocolized resuscitation strategy for patients in septic shock. I remember our surgical colleagues would snicker at this a little bit because we had been doing this for many years, resuscitating based on Shoemaker's criteria and pushing people with swans, and said, well, the medical guys finally got it, that if you resuscitate patients, they actually live. And that's what this paper showed. The third paper here is efficacy and safety of recombinant human activated protein C for severe sepsis. That was the Xigris wonder drug. So these were published in 2001. In 2004, the Surviving Sepsis Campaign released their first set of guidelines. And they had a lot of experts convened to review all this literature. And they made recommendations regarding these 3 topics, and they recommended all of them. They recommended early goal-directed therapy. They recommended human activated protein C, and they recommended that glucose control, although they suggested keep it less than 150 because you'll have fewer episodes of hypoglycemia. Well, turn the clock forward, 2016 guidelines. What do they recommend? Well, previous iterations have recommended a protocolized quantitative resuscitation, otherwise known as early goal-directed therapy. This described the use of goals. This approach has now been challenged following the failure to show a mortality reduction in 3 subsequent large multicenter randomized trials. No harm was associated, and thus the use of these targets is still safe and may be considered. I think that the reason recent trials haven't showed a difference is because it's become part of the culture to resuscitate patients. But nevertheless, the Surviving Sepsis Campaign is not specifically recommending that strategy. Recombinant activated protein C is off the market because of failure to show benefit in subsequent studies. And the glucose control is now recommended to be under 180, so not 80 to 110. So it's interesting how these high-impact papers do flux through our consciousness. Now, what constitutes adequate evidence? Here we have, really good evidence, great trials in the New England Journal. We follow them for a while. But what if there are no applicable randomized controlled trials? Sometimes innovation is the best option. And I have, I think many of you have heard the quote by Pasteur that chance favors the prepared mind. And there was nobody with a better prepared mind than Gene Moore. And I remember a case, I was just a couple months out of residency. I was on call one night, and an unfortunate young guy got shot through his liver. And it seemed like he had some bleeding from a retrohepatic caval injury. And one of my partners, Reggie Francios, he always used to hang around the hospital, and he came in and he said, "Hey, what you got?" I said, "Something bad." He said, "You ought to call Gene." So I called Gene Moore. I said, "Hey, Gene, what are you doing?" "I'm just eating a chicken dinner." I said, "Well, I have a pretty bad injury, a retrohepatic cava." He said, "You know, I was just looking at a case report about vena-venous bypass." He said, "Why don't you call the perfusionist and put the patient on vena-venous bypass?" So Reggie dug out the internal jugular vein, and I got the femoral vein, and Gene got there, and we put this patient on bypass, and we included some mesenteric venous decompression, and got a nice little case report out of it. And I don't think this patient would have lived if I hadn't had the boss to rely on with the preparation that he had by reading all the literature, and that kind of taught me I ought to try to keep up with it at least as much as my boss. Now, another innovation that many of you have probably heard of is this resuscitative endovascular balloon occlusion of the aorta. This is a surgeon from Australia showing it. And this, for those of you who aren't familiar with the Reboa, this was first introduced in the 1950s. Lieutenant Colonel Carl Hughes put an intra-aortic balloon catheter in 2 moribund Korean War casualties. Now, both the patients died, but in one of these patients, there was temporary restoration of blood pressure. So he suggested this ought to be further evaluated. Well, this is one of those things that kind of goes in the back of the mind, putting that information into the computer so it can spit it out sometime in the future. Well, nothing happened with this for a long time, and in the 60s and 70s, resuscitative thoracotomy became the standard means of controlling a lot of things, but including subdiaphragmatic hemorrhage with that aortic cross clamp. In 1989, this balloon catheter surfaced again in a series that was presented at the Western Trauma Association. The outcomes weren't good, but they were pretty much on par with what was currently being reported after thoracotomy. But notably, there were some pretty significant complications. They had a primary series in this study, but then they combined it and had 23 patients. There were 8 major complications. 1 instance of paraplegia that they attributed to the balloon catheter being inflated too long. There were 4 instances of the catheter exiting from aortic injuries and 3 instances of femoral artery thrombosis related to the catheter. So once again, this went away, and it came back recently. The US military was performing some studies, preclinical studies, not on these baby pigs, but their mothers were involved in that. And a collaboration between military and civilian surgeons was published, and Megan Brenner and Laura Moore really have been leaders in this area, and they published this series of 6 patients with good outcomes, rapid time to aortic occlusion, and this created an explosion of interest and application of this technique. The US Army incorporated this into their Joint Theater Trauma System Clinical Practice Guidelines relatively rapidly. This document was from June of 2014. Now again, there have been 6 patients in the literature at this point in time, but Reboa was put in there as an option for for torso hemorrhage control. In 2015, there were a lot of papers published about this, and the outcomes weren't all so good. This paper out of Japan reported 1 in 8 patients had an amputation of the lower extremity after this was done. Now, this is one of those cases where the innovation is great. It's apparently saved lives, but you got to put the brakes on. Is this really safe? Can it replace resuscitative thoracotomy, or does it make sense in various applications? So, talking to Gene Moore, and Chuck Fox was a colleague of ours who was in the military and a vascular surgeon, and we came up with a straw man proposal for the application of this that we thought made sense and could provide a basis for future study. So patients undergoing CPR, regardless of where the injury was, would get a resuscitative thoracotomy. Patients with a blood pressure over 80 should just go to the operating room or wherever they're going to go, because that is permissive hypotension, and we wouldn't put in any catheter that might be related with significant complications. But these other areas where the uncertainty lies, you can't use it for thoracic hemorrhage. So abdominal or pelvic hemorrhage, and the color coding here is red is more thoracotomy in the ED, yellow is REBOA, and green is the OR. So where to go with these patients, I think, should be a focus of research. We modified our pelvic fracture algorithm to incorporate REBOA for those patients with severe hemorrhagic shock. But these are questions that are currently being investigated. A lot of questions about adjuncts to insertion, whether you need how to assess where the balloon is, if it's in the right place, whether that's by measurement, by x-ray, ultrasound. Pre-hospital use has been proposed. That's a little frightening. Smaller diameter sheaths already appear to be making a difference in terms of those femoral artery complications. Using simulators for training, because this isn't something that anybody's going to be doing very frequently. And partial occlusion techniques can avoid things like mesenteric ischemia and that spinal cord ischemia we're talking about. So this is an innovation that will find a place. We don't know what that is just yet. Now, how about evidence, weak evidence versus expert opinion? What do we do with this in trauma? Which is more helpful? So many of you are familiar with the Eastern Association for the Surgery of Trauma, or the EAST Practice Management Guidelines. And these, the EAST group has focused on making these consistent with the best evidence-based medicine principles, asking PICO questions and evaluating the literature and coming up with their recommendations based on the quality of the evidence. And this practice guideline for emergency department thoracotomy was published a couple of years ago. And as you go through this, and they've got 6 different scenarios. And so the patient with signs of life after penetrating thoracic injury, we strongly recommend resuscitative ED thoracotomy, strong recommendation. For all the other categories, they are conditional recommendations. They conditionally recommend it, recommend it, and then patients who have no signs of life after blunt injury, they conditionally recommend against it. Okay, what is a conditional recommendation? So for the clinician, in the Western Trauma Association, in contrast, this is an algorithm that Clay Berlew led. The Western Trauma Association has taken the tack that we know there's not strong evidence or high-level evidence, but we want to offer people a path to follow, something to do, to lay out the conditions in the algorithm. So they come in, okay, are they undergoing CPR? Yes. Is it less than 10 minutes in a blunt trauma patient? Less than 15 in penetrating? Open the chest. If it's more than that, they're dead. But there's no role for scratching your head, doing CPR, giving some blood, and seeing what happens. The reason people don't do thoracotomies in everybody is because there are no survivors, or the survivors are neurologic invalids. So by scratching your head for 30 minutes and giving blood and getting them back, you've got a neurologic invalid. So this is, I think, a good pathway to follow. And again, this is expert opinion without much data. People still argue about this. Well, where do you come up with that? Well, we did a study of all the survivors, and the longest time period of CPR was this. We said if they're under that, then do it. And if they're over that, don't do it. So that's the data. It's pretty weak data, but it's something to do. And that's what we sometimes are left with in trauma. We've got to do something. We can't just stand there. Everybody's looking at us, seeing what we're going to do. Now, another thing that we have to deal with when we're looking at literature is, are we asking or answering the right question? Are the inclusion and exclusion criteria pertinent to the patient at hand? Are the outcomes of interest? Is this generalizable? So here's another Western trauma algorithm. Fred Moore wrote this one. It was published back in 2012, and this was on the management of complicated diverticulitis. And I'm just focusing on one aspect, and that is the grade 3, or the purulent peritonitis. And at the time, the only available literature on this subject with purulent peritonitis were a bunch of case series that suggested that patients did well if you just went in laparoscopically, washed out the pus, then they got better, they went home, and you could decide if and when to do a colectomy. Well, in the past couple years, some prospective randomized studies have been done, and they've all been done in Scandinavia. And if you look at the conclusions here, so this first trial, among patients with likely perforated diverticulitis undergoing emergency surgery, the use of laparoscopic lavage versus resection did not reduce severe postoperative complications, led to worse outcomes in secondary endpoints. These don't support it. Here, laparoscopic lavage is not superior to sigmoidectomy. Okay. But you have to read the whole paper. Now, in this study, the Dalala study, what they looked at was 12-month follow-up. Okay, who got one or more reoperations? Well, the lavage group, 28% of the patients did. The Hartmann's procedure, 63%. Well, are those all colostomy takedowns? No, half the patients still have a colostomy. So what is the endpoint of interest to the patient? Well, is it control of sepsis and avoidance of colostomy? Because if it's me, yes, those are the endpoints of interest. So I'll take the laparoscopic lavage and a 28% chance of having to go back to the OR over the 100% chance of colostomy and 40% chance I'll never have it taken down. I hope I'm healthy enough to have it taken down, but you know the data. 40% of patients never have them taken down. So this is the outcome of interest. And as you see these studies published, they're not addressing that. And I think that's what, when we're talking to the patients about it, is lavage superior to Hartmann's? Well, what is the outcome we're interested in? If it's just interventions during that hospitalization, that's not a fair comparison and not one that I'm interested in as a patient. So we have to talk about that. Now, involving patients and families, shared decision making, that's a good thing. A little knowledge is a bad thing. And I'm going to finish up with a vignette. Some of you have heard it, I think. Choosing wisely is a movement to advance the national dialogue around avoiding unnecessary medical tests and treatments. And one of the 5 things that the American College of Surgeons put forth is that we shouldn't do CT for evaluation of pediatric appendicitis until after ultrasound's been considered. So I have a story to tell you. August of 2014, I was on call at a hospital in the little hamlet of Boulder, Colorado, where they pride themselves on being different. A 13-year-old was in the ED with ultrasound-proven appendicitis, so I walked in the room with a consent form. The mother says, well, shouldn't we get a CT? No. Are you familiar with the radiation issues? Well, does she really need surgery? I said, yes. Well, I read that you can treat this with antibiotics. I said, oh. And I got all paternalistic. And I had actually given a talk on this a month before at the UC Health Emergency Surgery Conference. And I said, ma'am, let me assure you, I've reviewed the world's literature on this. The outcomes with antibiotics are inferior to surgery. If it were my daughter, I'd have her in the OR already. I said there's a 30 to 40% chance that she'll fail and have to have her appendix out. And that's what I would recommend. And I quoted her the Cochrane Review. And she's looking at me, and I'm looking at her. And one of us is thinking this. And she said, well, I just read a study where 28 out of 30 patients made it with antibiotics. And her daughter says, 93%. I said, I'm not familiar with that study. She said, well, I want to wait till my husband gets here. So I said, okay. So I went to my office, and there on my desk, still in its mailing wrapper, was that month's edition of JACS. And in that edition was this paper. 30-day outcome, 93%, just like that girl had quoted me. So I'm saying, you gotta be kidding me. So to complete the story, the father came. They didn't want surgery. The next day, the girl's miserable, examining her. Sorry, honey, tell your mother. Just went on like this. She was in the hospital for a week, still in pain, went home, came back to the ED 2 days later, got a CAT scan, had a phlegmon. guy on call wasn't going to touch her. And he said, what the hell's Biffle doing? Is he Scandinavia trained or something? And so this went on. And so I have a little bias against antibiotics for appendicitis, and I do believe it's supported by the data. Now, another thing, we need to read the literature critically. This paper recently published talked about trials they were non-significant primary outcomes. They talked about the bias or the spin that was introduced in these studies. So this is a prevalent problem, that the title or the abstract, the conclusions are going to have a little bit of spin. And so you have to be careful about what you're reading and how to apply it. So in summary, evidence-based medicine is a good general concept. We lack high-grade evidence for much of what we do in trauma and acute care surgery. We need to stay up to date, adopt sound innovations, and follow the data as they evolve. We need to read the whole article and not just the abstract if we're thinking about applying something to our patients. We have to evaluate each patient individually and apply the literature appropriately, and informed consent needs to be informed. And I thank Dr. Margulies once again for inviting me to do this, and it's been an honor.